Okay, good evening and good morning as well to one and all. This is the third session. I'll go straight for introducing today's speakers. I think Dr. Sunil Kumar is known to everyone in this group, but just as a formal introduction, Dr. Sunil has done diploma in pain and palliative medicine from Amrita Institute of Medical Sciences. He holds MSc in palliative medicine from Cardiff University, UK. Currently, he is working as the additional director of Trivandrum Institute of Palliative Sciences. With over 15 years of experience in palliative care, he is a very senior person as a all India faculty, and I welcome Dr. Sunil for this important session on methadone. Hello.
Thank you, Priya.
Yeah. So the other person who is speaking to us today is Dr. Theo. He is a clinical pharmacist who has completed his D Pharm and 2 years of postgraduate residency training in pharmacy practice and pain and palliative care. During his previous palliative care training, he had the opportunity to work with Pallium India directly in Trivandrum, Kerala. He is currently practicing as a clinical assistant professor at University of Iowa College of Pharmacy and an inpatient palliative care pharmacy specialist for 3 medical teams at University of Iowa hospitals and clinics. I welcome you both for today's session once again, and I must say that I am excited as all of you because this is the first time I'm also learning many things about methadone. Over to you, Sunil and Theo.
Thank you, Priyadarshini. Theo will be taking the first 30 minutes for the lecture on methadone, and then we will see how the discussion goes on, and we will plan according to that. So, Theo, it's over to you.
Great, thank you. And thank you everyone for having me here. Okay. So today we're going to talk about methadone, and the plan is we're going to cut methadone, since it's a big topic, into 2 major sections. Today I'm going to primarily focus on more specifically pharmacology, major chemical concepts, and some more practical monitoring concepts with the utilization of methadone. And on the next section, we'll be focusing a little bit more on some patient stories and also calculations and conversions of methadone. So after today's lecture, you should be, anyone attending this lecture should be able to describe the pharmacological properties of methadone, compare the benefits and risk of utilizing methadone for pain management, identifying and monitoring parameters for safe use of methadone, and recognize appropriate patients for methadone use in pain. So starting off with methadone pharmacology, there's 2 major indications that's often used for methadone. In the United States, it is used for opioid use disorder, but for our purposes in palliative care, we often use it for pain management. Usually, typical good candidates are patients that are having chronic around-the-clock pain, if they have renal impairments, and if a patient's pain show any neuropathic components, and if there's any concern of tolerance and hyperalgesia. Some of the adverse effects related to methadone are very similar to most opioid use. So that includes constipation, sedation, nausea, hypotension, and urinary retention. Some more chronic side effects that occur with chronic use of opioids include opioid-induced androgen deficiency, or OPAD, immunosuppression, and osteoporosis. And the more serious ones with opioids in general is respiratory depression. And what's a little bit more unique with methadone is a concern of additional serotonergic agents that may induce serotonin syndrome and QT prolongation. and ultimately that leading to potential causes of torsades, which we're most concerned about. So with the receptor activity or mechanism of action with methadone, it has quite a few actions, and that's what has some of the appeal of how it helps very well with pain management. So specifically, it works on the mu, delta, and kappa opioid receptors. So you can think of that as its major opioid activities. It also has the benefit of acting on the NMDA receptor as an antagonist. And this provides a lot of benefits with addressing neuropathic components of pain. And we find that that actually can help with concerns of tolerance or even hyperalgesia. In addition, it has activities on norepinephrine reuptake inhibition and also serotonin reuptake inhibition. So these two activities you can think of similarly to a SNRI or a TCA. And this is a component that may also help with neuropathic components of pain. And whenever we administer methadone, it typically is a mixed racemic mixture with two enantiomers. And that includes the S-methadone, which more specifically is related to causing blockade of the human ether agogo related gene, or hERG. And that is related to the expression of delayed rectifying potassium channels in the heart, which leads to QT prolongation. Versus the other enantiomer methadone, that one actually has much more potent analgesic activity, which is 80 to 50 times as much as its S enantiomer. And when we look at the pharmacokinetics of methadone, its bioavailability is pretty well absorbed. On average, it's around 80%. And when patients take it sublingually, it is around 30%. But when you administer methadone as a concentrate or solution, oftentimes it will also be swallowed down passively, which will have oral absorption as well. In the event that you have access to IV and PO methadone, an important thing to keep in mind is it is not a one-to-one conversion factor. When you switch patients from oral methadone to IV methadone, usually it's a 1 to 0.5 activity, or half the amount for IV methadone. And when we have patients on IV methadone and switching that to oral, we actually do a 1 to 1.2 milligram conversion factor. And this was all validated in studies. And it may seem odd that we do this conservative switch whenever we rotate it, but this has to do with methadone's ability to help with opioid sensitivities, and it's always taking a more conservative approach. And especially looking at its half-life, it does have a biphasic distribution, meaning that it distributes within plasma and also tissue. So when we talk about biphasic, that means that when it's first absorbed, there is a period of time where there is concentration in the serum, but it takes a while to have distribution into tissue. So you can think of it as a two-compartment model with pharmacokinetics. So when patients take and ingest methadone, it initially goes into the plasma, but there is substantial deposits into the tissue. So when we think about clearance for methadone, it actually has this equilibrium phase of needing to come back out into the plasma and then being metabolized by the liver. And with this, it has a variable half-life, but on average, it is around 22 hours. But in patients with hepatic impairment, it actually can extend up to 120 hours. So this will be a key concept when in the next section, we'll talk about dosing, titrations, and steady state. but for its analgesic duration, we've actually found after repeated dosing, patients have analgesic benefits for 8 to 12 hours after methadone dose. In regards to its metabolism and clearance, methadone is extensively hepatically metabolized. So we do caution dosing in patients with hepatic dysfunction. And just to clarify, this is not a contraindication, but keeping in mind that means that the body will be breaking methadone down slowly if there is some hepatic impairment. However, I would generally recommend avoiding it if there is unresolved biliary obstruction, since this is a pathway for its methadone and its metabolized excretions. Sorry about that. And with its metabolism, a lot of the systems that we're worried about is the cytochrome 450. And the specific ones that we're looking at is CYP2B6, 3A4, 2D6, and 2C19. And the other minor enzymes are CYP2C9 and 2C8. So as you can tell, with all of these CYP enzymes that methadone is dependent on, this will have many drug interactions. And ultimately, this may impact your clinical decision for considering methadone and or dosing, depending what other medications patients may be on. And of note, the CYP2B6 and 2D6 and 2C19, there is going to be some pharmacogenetic variation between populations that we find. So it isn't always an exact amount or rate that patients are metabolizing it, and it can be dependent on their specific genes, similar to codeine and its conversion to morphine. So when we talk about some of the monitoring parameters and concerns with methadone, the biggest one is going to be the risk of causing torsades or QT prolongation. So when we're evaluating patients for candidacy for using methadone in pain management, some of the things we'll look for are risk factors for torsades, which can include electrolyte abnormalities, specifically potassium, magnesium, and calcium. Patients that have an age over 68, female gender, structural heart disease, genetic predisposition to torsades, and if they are also on any other QT prolonging medications, history of syncope, and a previous QTC over 450. So patients that have one risk factor is found to have an odds ratio of 3.2 versus baseline for having torsades, and then patients that have 3 or more risk factors have an odds ratio of 9.19. So we can think of this as if patients are having more risk factors, we may be a little bit more keen on being concerned about its use or needing to monitor its use much more closely. And other predictors for QT prolongation include heart failure, hypokalemia, hypocalcemia, and as we also mentioned, patients already taking medications with a torsades risk, rheumatologic diseases, malignancies, peptic ulcer disease, and methadone doses over 45 milligrams a day. So when we start patients on methadone or are considering starting it, we do have some recommendations, and some of them are related to monitoring specific labs, but the most important thing is making sure that we're aligning our monitoring with the patient's goals of care and weighing this against our risk factors. So doing routine scheduled aggressive labs and ECG follow-up may not necessarily always be warranted for patients, especially with comfort-focused care and have minimal risk factors. but these risks and benefits should be discussed with patients, especially if they may not have access to obtaining all these tests and labs. But we do, in the event that we do think that they may still have a lot of benefit to gain with methadone in regards to symptom management. But generally, when we start methadone, we usually like to have some baseline information if possible. So this includes the ECG and also the electrolytes, which we talked about, which are at higher risk of having QT prolongation if they're low, which is potassium, magnesium, and calcium. And one line I forgot to include in this is also knowing baseline liver function if there's signs of dysfunction. So LFTs and looking at that. Typically for patients, once we start methadone, we usually do a ECG follow-up 2 to 4 weeks after. And that would be at certain phases, which is initiation of methadone. And when we reach certain dose thresholds, which is 30 to 40 milligrams a day and 100 milligrams a day of methadone, or if there's any new risk factors or signs and symptoms that may suggest an arrhythmia, just to make sure we're still continuing its safe use. And then always wanting to monitor for its adverse effects, and then waiting sufficient time for steady state before making any dose adjustments. So relative to methadone's half-life, which we said was on average around 22 hours, a rule of thumb for steady state is 3 to 5 times its half-life is its steady state period. So typically we don't recommend any adjustments on dosing at least 5 to 7 days, and actually extending it to 10 to 14 days in patients with advanced age or hepatic impairment, because these are populations that typically have a little bit slower metabolism or breakdown of methadone. So I know we talked a lot about its adverse effects and monitoring, so it does sound a little bit, it may sound a little concerning to some, like, why would we use this? So there's actually a study in MD Anderson that was a prospective study. They did a population of 100 cancer patients at MD Anderson. They monitored ECG changes at baseline, 2 weeks, 4 weeks, and 8 weeks. And the results of the study was that the baseline prior to initiation, 28% of patients already had a prolonged QT. And the median methadone dose in the study was 23 milligrams a day. And at 2 weeks, 31% of patients had prolonged QT, and only 1 patient had an incidence of a QT over 500. And no patients had a greater than 25% increase of QT from baseline. And there was no reported events of torsades or ventricular fibrillation. However, the study did have a limitation since there was significant dropout through the different periods of time. Is this to say that there is no risk with methadone? No, that's not necessarily the case, but we can see from the study like that there is the ability to safely monitor and utilize methadone, and it may have a lot of benefits for our patients in regards to symptom and pain management. And the next thing I wanted to go over is drug interactions. So I know we listed a bunch of CYP enzymes, and that's a little overwhelming. I always recommend if you can use a drug interaction application to check for these, that would be helpful. But with my pharmacy education, a common mnemonic that we've used from different pharmacy schools is GPACBAN, which G is for grapefruit, P is for protease inhibitors, A is for azole antifungals, so including fluconazole, and then C is for cyclosporin, cimetidine, and cobicystatin. M is for macrolides, amiodarone, and dronedarone, and non-DHP-CCBs. So these are going to be inhibitors that may cause a slower breakdown of methadone, meaning that there will be elevated levels of methadone when we start these medications. Versus when we look at the other end of CYP inducers, meaning drugs that may cause an elevated expression of these enzymes that may break down methadone faster, these will lead to a lower level of methadone. And this mnemonic that we've used in pharmacy school is PS-PORCS. So it's phenytoin, patients that are smoking, phenobarbital, oxcarbamazepine, which is a weaker inducer, rifampin, rifabutin, rifapentadine, and carbamazepine, and St. John's wort. So the most important thing to keep in mind is if it is possible to avoid using any strong inhibitors or inducers, try to use alternative therapies first when patients are using methadone, or if we're anticipating we may want to switch and utilize methadone. When we talk about inhibitors relative to inducers, you will see the peak effects of inhibitors around 1 to 2 days, versus the peak effect of inducers may be a little bit longer, since that's impacting gene expression. So you might not see the full effects until 1 to 2 weeks later. So what are the recommendations? What if we have patients that are on these agents and it's a little unavoidable, or if they're on an agent already and on methadone and they need to stop it? So whenever we have any patients that are going to be starting an inhibitor, or if they are on an inducer and on methadone and we are planning on stopping it, empirically we recommend that we reduce methadone by 25 to 33%, because in these two scenarios, we anticipate methadone levels will increase. And we always want to monitor carefully for adverse effects, concerns of if there's elevated methadone levels, are we worried about respiratory depression or other side effects that may pop up. And in some instances, there could be not a significant amount of increase, but patients may have more pain. But the most important thing is being conservative and monitoring, and we can always adjust a little bit later. Versus on the other end, when we are stopping an inhibitor or starting an inducer, in these instances, we anticipate methadone levels may actually decrease. We actually don't recommend that you preemptively make any dose adjustments. You should really monitor carefully and see if there's any signs for increased pain or withdrawal symptoms, and provide adequate breakthrough medication in the event that patients have worsening pain. And then as time goes on, we can always adjust the methadone dose to the scenario, or if they need more. Versus if we preemptively increase it, we may induce respiratory depression, which is something much harder to manage. So when we think about patients that would be appropriate for methadone, typically we're thinking of patients that are having moderate to severe pain, if they're having refractory pain to other opioids, if they have significant renal impairment, and this is the case because methadone is not substantially cleared through the kidneys. End-stage renal disease is actually a good population to use methadone in, because the small proportion of methadone that's typically cleared through the kidneys is actually can be diverted and excreted through the feces. Another good candidate would be patients that are needing long-acting opioids. If you only have morphine and methadone available, methadone would be a good instance for this for patients that need around the clock, every 4-hour morphine just to have pain relief. If you suspect patients are having high opioid tolerance or on very high doses, this may actually help with that. And patients that are having poorly controlled opioid-induced adverse effects with other opioids, including concerns of maybe myoclonus and renal dysfunction from morphine, this may prompt you to think about methadone. And also any patients that are having true morphine allergies, then methadone is actually a different class of opioids where we're not worried about this cross-reactivity allergy. And for certain populations, these aren't necessarily contraindications, but these are going to be risk factors that you might want to take a little bit of time and pause and think about it if benefits outweigh risk. And this includes structural heart disease, a QTc between 450 and 500, severe chronic liver failure, meaning that they would break down methadone very slowly, but it's not necessarily a contraindication. A history of non-adherence to therapies, meaning that they have trouble taking medications on a scheduled basis. This may be concerning since it will be hard to safely dose adjust and monitor the patient. And patients that have history of sleep apneas, including central or obstructive sleep apneas, they may be at higher risk of respiratory depression. And if they're having multiple non-modifiable drug interactions, this may also make it difficult to dose. And if patients are having multiple non-modifiable risk of torsades or QT prolongation, this may increase that risk for torsades, which we are concerned about. And for these populations, this is groups of patients that I would probably think about not using methadone because the risk will likely outweigh the benefit. And this would be patients with a history of sudden death, congenital QT syndrome, a QTc of over 500 without modifiable risk factors. And remember, some of our modifiable risk factors are if they're on other drugs that may be inducing this QTc of over 500, or if they have low potassium, magnesium, and calcium. If it is over 500, you can try to reverse these or correct their electrolyte abnormalities and do a repeat and see if that normalizes. But in other risk factors, such as the structural heart or the other risk factors that we talked about previously, and that's what is inducing the 500, it'll likely be that their QT will stay over 500. Patients that have poor cognitive function and or live alone without reliable caregiver support. Again, if patients aren't able to take methadone consistently, or if they may be prone to not following directions and taking too much because of methadone's long half-life, that is very concerning and dangerous. And patients that have the inability to obtain follow-up, again, this is a medication that does need to be dosed by someone that specializes in pain and really understands the use of methadone. So if they are unable to routinely follow up with you when needed, this may not be a good candidate. And then patients that have active illicit drug use or misuse, including cocaine or amphetamines, this will have a higher risk of causing torsades as well. And other populations are trying to utilize methadone in an acute pain crisis or acute pain management. Methadone is not appropriate because of its long half-life and difficulty with titrating it. So it is actually dangerous to try to hope to manage an acute pain crisis with methadone because that steady state period will take at least 5 to 7 days. So if you did a very high dose where patients may respond initially very well, that is concerning since it'll still take time to build up in tissue, which they may be at higher risk of overdosing. So generally, we do not recommend that being used in the setting of acute pain crisis. And then in patients that have an acute liver failure, we also don't recommend the use of methadone. Okay. And again, so this is everything that I wanted to kind of touch base on with the pharmacology of methadone. The next session will be focusing on methadone dose calculations and conversions. Thank you.
So, thank you very much, Theo. That was really giving good perspective about methadone. So, Sunil, would you like to start?
No, before that, I would like participants, if they have any questions, they can ask now. I'm not switching on my video because of poor coverage.
Okay.
Anybody has any doubts?
Sir, good evening, sir. It was a very nice presentation. Just I wanted to ask, since we need to monitor QTC, we have a lot of things to monitor while on starting and selecting to choose methadone. So, is it a good drug for an outpatient basis, or we need to admit the patient first, monitor him, and then send him home uh, with a maintenance dose?
So with initiation of methadone, you can initiate this on an outpatient basis. And actually, on our outpatient clinic, we actually often actually start methadone in that setting and in the home setting. And in some instances, it actually can be a little bit more ideal to do it in a home setting as long as you have that baseline monitoring, because typically you won't do a follow-up to do dose titrations until at least 5 to 7 days, versus if we initiated in the hospital setting, you typically want to keep them in the hospital a little bit longer to monitor them for. So I wouldn't actually, I would say that it is absolutely perfectly fine to start this on an outpatient basis.
Thank you, sir.
So we also had the same problem when the methadone was available for the first time in 2018, and we were very reluctant because of the side effects that were mentioned by Theo. But after that, we understood it is not much a problem if we use it properly. We need not make the patient inpatient for starting methadone. We can do it in outpatient, and most of our patients, 95% of patients are started on methadone only on outpatient basis. And in home care also, you can start methadone, but somebody should be following up the patient maybe for 7 to 14 days. If possible, every day, somebody calling the patient and checking up if they have any problem. So we can start methadone in home care, outpatient, or inpatient unit.
Thank you, sir.
Dr. Sunil, there's a question in the chat, how to procure methadone in Kerala.
Okay, so if you have RMI license, that is recognized medical institution status, then methadone comes under RMI status. So it is available in one agency in Kerala. So if you have RMI status, you can procure it. It is very easy. There is nothing extra thing needed, only the RMI status.
Yeah, can I ask one question, please? Can I ask
Yes,
one
please.
question? Dr. Theo, you mentioned that female was a risk factor. Why so?
So I think when we technically look at normal normal ranges of QT, males are actually around 430 and females are, or what the upper limit of normal is. And for males, it's 430, and in females it's 450. So I think that's just kind of what we found.
Okay.
So, Sunil, there are a few questions in the chat box. Nivedya is asking, we use plastic bottles to give away methadone. How do you pack it for your patients?
Actually, we provide a bottle itself. Actually, the syrup methadone, it's 150 ml. So we usually provide one bottle to the patient. So Theo, do you have any idea if you can use another bottle to divide this methadone and give it to 2 or 3 patients? What type of bottle should be used?
So from the US, I think they typically use like plastic bottles to distribute different liquids. I don't believe that there's any concerns about it like adhering to the plastic, but usually like a dark colored bottle just to prevent light
Yeah,
from
Theo,
degradation.
I just have a doubt. I'm Dr. Nivedya. The doubt is, it comes as a huge package, and we find it more cost conservative, or it's more easy to save on the medicine when we distribute it among people, because you don't need much of a dose for everybody. We give it weekly once, so we ask the patient to come back and take the rest of the methadone another day. So we use small bottles. We use the needle filler, and we measure the methadone and give it to them, and we titrate their doses accordingly. So is this how you're doing it, or how do you do it in your setup is what I want to know. It's not about
Yeah.
plastic at all.
Okay. Yeah. So typically we distribute the amount of methadone in either tablets or liquids based on how much we anticipate they'll use until their next follow-up. And obviously just a little bit extra just in case if they miss an appointment and need to come back a little bit later. But that's also how we practice. We send these prescriptions to our pharmacies and they fill them in small containers accordingly.
Right. Thank you.
Okay, so
So, Dr. Nivedya, how will you account the methadone syrup if you divide it for 2 or 3 patients?
Yeah, Dr. Sunil, actually, the methadone syrup is not given by the pharmacy in our hospital. It's given by our department, anesthesia department, holds stock of the methadone. So we use it, we keep a bottle of it, we distribute it among patients and keep the rest of the bottle again with us and distribute it again when another patient needs it. So we keep one bottle as a stock in between, we indent it from the pharmacy and we keep it with us.
Yeah, so I definitely agree with that, of keeping your major stock bottle. And for the amount of methadone that you're distributing, you should back calculate based on what dose you anticipate the patient should be using on a daily basis and extending it to your 2-week follow-up and giving them that much volume on how much they need and maybe a little bit extra just in the event of something happens and their patient misses an appointment and may need to come the following week, just to give them a little bit of leverage.
Thank you.
So, Dr. Sunil, can I ask one question? This is Priya. So the thing is, if we are giving syrup methadone to multiple patients from one bottle, and then are there any regulatory things like we have for morphine, and they have to sign? And how do we control that the scheduled quantity is going to that one particular patient? Any thoughts on that?
Yeah, actually, we had a problem with this because right now the methadone supply is short in India, and syrup is the only thing which is available as of now. We were providing a bottle itself to the patients previously, but now because of shortage, we are trying to provide methadone syrup to 2-3 patients, but the documentation I'm not very sure, so that's why I asked Nivedya what they are doing.
Because I guess if we are falling short in the documentation of filling this opioid forms, then it could be a problem.
So we maintain a register and we fill the names of the patients with the ID, the IP number, and we sign for those patients who are given methadone. But we titrate it and give it from one bottle into multiple small bottles. So we write down the names, but we do not accommodate for one bottle a patient. We write down for all the patients who we actually distribute methadone.
The other question would be like, since we are shifting it from one huge bottle to a small bottle, is there a possibility that uh, even if you want to give 10 ml or 20 ml, it may be actually less, and there is a accuracy differentiation in the dose as well?
We use
Yeah, that
inhaler, ma'am. So we measure and we
we
give.
need to be. Yes, Nivedi, go on.
Sorry, sir. We use an inhaler to measure and give the dose. So I don't think that kind of a dose inaccuracy should happen. So far, it has not.
Priya, I think it's if we take it in syringe, it should be okay. But when we measure, we should be very careful. Otherwise, there will be some miscalculation, especially with syrups. If somebody writes 1 ml or 1 mg, some people may administer 1 ml instead of 1 mg. Actually, methadone syrup 1 ml contains 5 milligrams. 1 ml contains 5 milligrams. So this is something which we need to be careful. So as far as possible, we are avoiding syrup, and I know that syrups are not good because of this reason, and they have to shake it every time when they use it. They avoid the direct sunlight, etc. So
Yes.
the caregiver should be able to take required amount in a syringe. So all these we should be very careful. So we are avoiding the syrup as much as possible because of possibility of miscalculation.
Yes, thank you. Because I'm just highlighting this because many years back, when I was observing palliative care services in South Africa, and they were using liquid morphine in home setting. Typically when the particular service I was visiting, they had liquid morphine refills done by nurses on each visit. And then I always had a query, like, there is a risk of contamination when you are adding to their present bottle in their house, and then the accuracy. So Theo, do you think it is a problem, or how do you do about syrup methadone back home in US?
Yeah, so in the US, I guess it may not be applicable because we always send it out to the pharmacy and they typically always give a new bottle. However, the other thing that I wanted to point out is if you do use bottles and you do transfer it, keep in mind that you don't want to always just be distributing the exact amount that you anticipate, because there is going to be a little bit of adherence and volume loss because it's just stuck on the bottle, and that's just like the nature of syrup.
Yes, thank you. So the next question is by Dr. Bharat. Do you want to talk, Dr. Bharat, about dosing and all?
Excuse me, can I
Uh,
just hop in for a second?
Sure, please.
Excuse me, we will talk about conversion, I think in the next session, and dosing. I did want to make sure that the cost question was addressed. Regarding cost, is it costly compared to morphine?
It's almost comparable to the equivalent dose of morphine in India. And if the patient is on higher dose of morphine, then the cost of methadone will be less. So it's almost comparable.
okay, thank you.
Yeah. So Deepak, you have a question there or a comment? Deepak, okay.
Not
So
exactly a comment, but I think in India, one thing that will this thing is the reliable having access to a reliable caregiver, because those doses can be quite small, 2 ml, 2.5 ml. So measuring it correctly is the I mean, it's doable. It's not like it's very difficult, but it is something that has to be. So if it's someone who's living alone on their own, that kind of thing, then
Yes, Deepak, I agree with you. So one of the most important points to consider before starting methadone would be a reliable caregiver. It is not like morphine, because if you give morphine 5 milligram extra, it may not cause much problem. But if you continue to administer methadone in higher dosage, then the side effects would be more compared to morphine. So we should have a reliable caregiver who can actually give the required dose. So that we need to consider before starting methadone.
Right. So, are there any other questions?
Ma'am, I just wanted to ask one thing.
Yeah. Who's this, please?
This is Dr. Geetika.
Okay. Yeah.
Yeah, sir, is it that if we have an evidence of a, variation in the QT, so we need a reference before starting, or maybe a while after it is started?
Theo has mentioned in his lecture that all the patients doesn't require each and every investigations. So if you are primarily focusing on the comfort care, then even if it is not possible to get a ECG, start with small dose and it should be fine. But if there is a patient who is on treatment with curative intent or patients with the chronic pain, then it should be good to have a ECG and other investigations.
Thank you, sir.
Yeah, and in the events where there, like Dr. Sunil said, if ECG is not possible and it's not possible to have labs, relying on looking at what risk factors does this patient have. If they don't have too many risk factors, it may not be as much of a concern versus if they have 5 risk factors, then I might be a little bit more hesitant.
So if you, may I ask a question? If you are taking a baseline ECG, then after that, if the patient is continuous on methadone, so when is the next ECG due, or is it necessary serial ECG should be done? What do you suggest?
So after the initiation, usually 2 to 4 weeks is when we do a repeat just to see what the reaction was to methadone. And then when they hit certain dose thresholds, so 30 to 40, or when they hit 100 milligrams, typically you won't have patients go that high on methadone for pain. And then if there's any additional risk factors or signs that patients might have an arrhythmia or new drugs that might increase that risk.
Okay. Any more thoughts or comments or questions at this point?
Today, yes. Hello, ma'am. I'm Dr. Suraj. I have one question. Is there any limit of liver function test that this should be not given after this much increase of bilirubin? And is there any limit for the same in methadone?
Sorry, I didn't understand the question.
Is there any limitation for bilirubin, increased bilirubin, deranged liver function test?
So probably what he's saying is once you start a patient on methadone, when would you check liver functions? How frequently, and should we do it regularly? Is
So
that
I think
right,
just
doctor?
Yeah, that is also
No, I think
actually.
he's asking whether what is the upper limit
Yes.
for which we can methadone if the bilirubin is high. There is no such criteria can be laid down, but it is said that even if patient has child book score C, even then we can start methadone, but it would be better to wait for 14 days before we increase the dose of methadone. Because in liver failure, it will take more days to stabilize the bilirubin. So potential that it is in the obstruction, it would be better to avoid methadone. So I know about the bilirubin level, but this is what mentioned in literature. Theo?
Thank you, sir.
Yeah, so that's my same sentiments. If they have liver failure, there isn't necessarily a defined threshold, but generally it just means starting off much more conservative with dosing and dosing much slower.
From what I understand, I think it was told that one of the contraindications is severe hepatic impairment, not moderate or mild. So there are certain LFT values for severe hepatic impairment on which even chemotherapy is based. So I think when that LFT values, I think it's about 2 to 3 times the SGOT, SGPT as well as below a particular value. Then you avoid using methadone. And if it is in a moderate, I think we should do at a lower dose as you suggested, because we know that the toxicity is going to be the breakdown will take longer time. As far as renal function is concerned, I don't think there is any contraindication.
And so on the chat, I see a question, is it a good indication to start methadone in intestinal obstruction? So I guess that is a question that really depends on what is the cause of the intestinal obstruction, because any opioid may worsen intestinal obstruction. So I wouldn't use it to treat that. But if patients have obstructions that can't be managed through surgery or other interventions, and we are now focusing on pain and symptom management, then I think that would be reasonable to use.
Rajlakshmi, we had a few questions which is like a review of this lecture. Can we project this and ask the participants to vote for that?
Yes, sir. Yes,
Sure,
sir.
sure.
So I'm launching the
So
poll.
all of you, please. Yeah.
So we have 10 questions coming in front. Do select the most appropriate ones. I hope all can see the screen now.
BD or TID dosage. Methadone can produce torsade points, especially in higher doses, which can lead to sudden death. That's true. So we have seen an MD Anderson Cancer Center study in which they haven't found any torsade points. It is especially true when patient is on higher doses of methadone, and patients who are taking methadone for oral substitution therapy may be prone to torsade points. And methadone has the following action except, methadone has many mechanisms of action, and that's why it is a particular or special opioid. And it is useful in neuropathic pain and in opioid-induced hyperalgesia and opioid tolerance as well. So it acts on mu receptors like morphine, but it also has agonistic effect on kappa and delta receptors. And it's an NMDA antagonist. So it acts like ketamine. And it also has tricyclic antidepressant-like action. So it inhibits the reuptake of noradrenaline and serotonin. So it doesn't have prostaglandin inhibition. So prostaglandin inhibition is the right answer here. The risk factor for torsade point starts at corrected QTC at 250 for 50 milliseconds and is significant at 500 milliseconds. That's right. So if somebody has corrected QT interval more than 500 milliseconds, it is a contraindication to start methadone. So you can use many formulas to calculate corrected QT intervals. There are many formulas, and even an online app is available to calculate the QT dosage, which you can download. Methadone has NMDA activity that is equal to ketamine. So actually, I was not sure the answer of this question till 2 days back, but I was looking more on methadone, and I got a reference which says the NMDA activity of methadone is equal to ketamine. And methadone is mainly metabolized in liver. We know that there are many cytochrome P enzymes are involved in the metabolism of methadone. And I would like to add one more thing. We saw that from Theo's presentation, many medications has interactions which we usually use in palliative care, has interaction with methadone, and it can increase or decrease the levels of methadone, and some can also prolong the QT interval. But we have to be careful because the Ayurvedic medications and homeo medications can also interfere with methadone. So in case if somebody is taking other medications, we should ask them, are you taking any other systems of medicines? Which is correct regarding pain relief. Methadone and dextropropoxyphene are safe in chronic kidney disease. Methadone and codeine are safe in chronic kidney disease. Methadone and fentanyl are safe in chronic kidney disease. Morphine is the safest opioid in chronic kidney disease. So we know that morphine and especially its metabolite morphine 6-glucuronide accumulate in renal failure. So it is not very safe in chronic kidney disease. Likewise, codeine also. Dextropropoxyphene, the metabolite norpropoxyphene can also accumulate in chronic kidney disease. So here the correct answer is methadone and fentanyl, which can be used in chronic kidney disease. The oral bioavailability of methadone is as follows. It's 70 to 80%. So you know that the oral bioavailability of morphine is about 20 to 30%, or 10 to 20%. Methadone can be administered through the following route. So methadone can be administered oral, parectally, sublingually, subcutaneous, and intravenous. In case of morphine, we know that sublingual absorption is not very good, but here 30% is the bioavailability after sublingual absorption. So methadone in concentrated solution can be used for sublingual administration. So oral, parectal, sublingual, subcutaneous, and intravenous routes can be used.
So the answer is
methadone.
The correct answer is shown to be last option.
No, that's not the right one. The oral, parectal, sublingual, subcutaneous, and intravenous can be used. Methadone blocks human either agogo related gene in myocardium and can lead to increased QT interval. That's right. So human either agogo related gene is abundant in myocardial tissue. So if it blocks the HRG related gene, it can increase the QT interval, and it can lead on to polymorphic ventricular tachycardia, and which lead on to Tausert points and sudden death. So actually we had 5 more questions.
Sir, you want to administer it now?
Yeah. We have 5 more questions.
I hope you can see it in the screen right now. Questions 11 to 15. Please to answer it.
Of the review of the lecture. It's all of
Sorry.
that.
Sorry.
Sir, it's accept, no sir?
Was it accept?
Sir,
Okay.
Sir, I'm
Yeah,
asking.
all the
May
above
I ask a
conditions
question?
you can use methadone.
Hi, sir.
Sorry?
So the answer should be None of the above, right?
Actually, sorry, I can't see the question, but all the conditions, yeah, let me see. Following are the indications to use methadone except, yeah, none of the above, yeah, because all the above
Sir,
conditions
how
you
is
can
it used
use
as
methadone.
adjunct?
So you can see there are many
Sir,
literature
how?
on, yeah, there are literatures on methadone used as an adjunct. So if you are using methadone as an adjunct, maybe 1 or 2.5 milligram is used in addition to the opioid that you are using. If the patient is on morphine, 10 milligram for hourly, and patient has almost good relief, but not up to the satisfactory level. So in such patients, you can add some 2.5 milligram or 1 milligram according to the age. And if in doing that, the patients can have a good relief of pain. And that's how it is used as an adjunct. So in the real sense, it is the definition of adjunct. Um, it is not a primary indication is not analgesia, but it is useful in some painful conditions. But here, methadone itself is an analgesic, but even then, it is told us it is used as an adjunct if you use it once daily for a good pain relief along with other opioids. So I think we can move on to patient story.
Great, thank you.
Okay.
Let me share my
One more
screen.
question. Hello. One more.
Okay, sir.
I think there is one more question.
What is
Okay.
the starting dose? You didn't mention about the starting dose. That's so you are
So
yet to
we'll,
discuss. You are yet to discuss
yeah.
that.
Class.
Okay.
How to convert some other opioids to methadone. And
Yeah,
would
so
you
the,
like to talk?
Dr. Sunil, I have very unstable internet this very second. Did you ask me a question?
No. If you want to make more points, please.
No, I'd love to hear the case. And I think people are asking great questions and they will be covered next week.
So should we go to next case discussion, Theo?
yes, we'll move on to the case. One question I saw is, can methadone be used for breakthrough pain? I would not use it for breakthrough pain. It should be the morphine or any short-acting opioids. You would want to treat the methadone as a basal. Okay. Okay.
So just to remind, it's 8:13 already.
Oh, okay. So we'll kind of rush through this case a little bit since we're a little behind in time. So in this case, it's a 57-year-old male with stage 4 pancreatic cancer with metastases to spine and liver, with also a history of hypertension, diabetes type 2, and CKD. The patient presents to your outpatient palliative care clinic with concerns of uncontrolled pain in his back and legs. So history of illness, he was diagnosed with pancreatic cancer a year ago. He was initially well managed with ibuprofen, paracetamol, and a few doses of morphine. However, his disease has continued to progress with new lesions in the liver. With that, his back pain has progressively worsened as well, and the patient required additional doses of ibuprofen, which led to an AKI. More recently, they found new lesions in the spine on X-ray and MRI, and he's already completed palliative radiation for the spinal metastases. So on an examination, lab results that he had a month ago was a serum creatinine of 2.4, leading to a estimated creatinine clearance of 25. Sodium was within normal limits. Of note, potassium was slightly low, and there was some decreased renal function. some elevated glucose, slightly elevated liver function tests, and low albumin. Vitals were within normal limits. The patient reports that their bowel movements have been normal, but they said their last stool was 5 days ago. On the MRI, it showed extensive osseous metastases throughout the spine. There's pathological compression fractures of L1 to L3, but no spinal cord compression. The metastatic lesions involve the sacroiliac bones. On physical exam, no acute distress. On head, there was some mild temporal atrophy, but normal cephalic otherwise. Cardiac, regular rhythm, lungs, clear auscultation bilaterally. GI, faint bowel sounds, extremity, +1 lower extremity edema, but no lesions on their feet. Neuro, intact, no signs of myoclonus. So with patients' history of treatment investigation, they were initially diagnosed in June 2020. Lesions were considered inoperable of the pancreatic cancer. They completed 2 different chemotherapies, including FOLFIRINOX and paclitaxel and gemcitabine, and also received radiation therapy for the spinal lesions. When you are doing a pain assessment, it's always important to get an analgesic history of what medications they have tried in the past for pain. So in this case, patient tried gabapentin. They did not note any pain relief from it, and they've went as high of doses of 1,800 a day, and it only really caused sedation. They've also had ibuprofen in the past. There was some mild relief, but they were told to stop because of this kidney function issues. They also have tried amitriptyline in the past. It helped with pain, but they really couldn't tolerate the side effects of dry mouth, and they had some confusion with it, so they stopped it. And last week, they actually did a 5-day burst therapy of dexamethasone with minimal relief. And then they had previous conversations of trying a fentanyl patch, but that was just too expensive for the patient. And of course, when we do pain management, it's always important to do a very thorough pain assessment. So in this case, on our pain assessment, they had back pain. They note that it's constant pain with some spikes or flares in pain. They note it to be sharp, burning, and achy pain. Sometimes there is radiation that shoots down their legs. They note that severity is 8 out of 10, and the best it ever goes down is 5 out of 10, and that's with morphine. The palliating factors is the use of morphine and really not being mobile and laying on their side. Some aggravating factors is sitting and walking. So the overall impact of their pain is difficulty walking and sitting, limited ability to do work around the house. He's currently unemployed because he's unable to work because of the pain, and it's leading to poor sleep. The patient also notes pain in his legs. It's always continuous. He says that there's pins and needles with some numbness, but more recently, he notes that it feels like it's sandpaper whenever anything touches his skin. There's no radiation of it, but the severity is 2 out of 10. The worst it gets is 5 out of 10. Nothing really helps with the pain. Things that make it worse is touch and abrasion, and it leads to difficulty with walking and sleep. So key things I wanted to note is when we look at when patients are describing things like allodynia or very sensitive sensations to touch that's painful when it shouldn't be with normal stimuli, that gives you a sign that this may be hyperalgesia if patients are on high doses of opioids. And this pins and needles with numbness is actually not what we think about with hyperalgesia or allodynia. This is likely residual or sequelae from their diabetes, right? So that's a typical diabetic neuropathy presentation. And I'm rushing through this because we are a little limited on time. So I apologize about me speaking a little faster. For psychosocial aspects, he is currently widowed. He had 2 children. However, one daughter died from labor complications, and he currently has 1 son who he lives with, and he supplies most of his support and helps with his medication. He's previously worked as a carpenter, but is no longer able to continue working. For current medications, he's taking hydrochlorothiazide, 25 milligrams. He's taking mealtime insulin and basal insulin. And of note, he's taking ciprofloxacin, 500 milligrams daily, which was started 2 days ago for suspected UTI. He's currently taking a PPI omeprazole. He's also taking paracetamol, 500 milligrams Q4 SOS, and using 5 doses a day. And in addition to that is morphine 60 milligrams PO, Q4 SOS, and he reports using 6 doses a day. Sometimes he uses 7 because the pain is really bad. So our main concern is uncontrolled pain and financial distress. What interventions would you consider in this case? So usually I would ask for input, but since we're limited on time, I might just kind of move forward. So when we think about this patient's types of pain, there is clearly some bone pain. So there is bone metastases. So some therapies you can consider is bisphosphonate. However, due to his renal function, it's contraindicated. For his neuropathic components of pain and also diabetic neuropathy, you could consider duloxetine. But again, with their renal function, this is actually a contraindicated medication. When we want to think about interventional medicine, this patient doesn't have any clear regional or sympathetic blocks that would be beneficial. And actually, because he has an active UTI, it's currently contraindicated. We would want to think about TCAs for neuropathic pain, but clearly he noted that he was unable to tolerate that, so that's no longer an option. And this is a side note that you never want to use. I generally would not recommend using a TCA in addition to methadone because of QT prolongation risk in the event that they were still on it. And NSAIDs shouldn't be used in CKD. And when we look at the OME requirements, it was actually quite large. So another opioid that sometimes is thought about is buprenorphine. However, based on his OME requirements, that is well above the benefit that he would likely get from buprenorphine. And actually, if you started buprenorphine, you could be at risk of precipitating withdrawal. And in regards to steroids, that may help, especially with spinal pain and related to that. But there was no core compression, so it was not too surprising that was minimal relief, but he's already tried that. And then some people may think, let's consider a basal opioid like fentanyl patch. But in this case, the patient wasn't able to afford that because it was too expensive. And of note, fentanyl wouldn't necessarily help with neuropathic pain substantially as much as another opioid such as methadone. So in this case, methadone would actually be a good option. So what additional tests would you want to consider in addition to what we already have? So in this case, we did not have an ECG. We had a potassium, which was somewhat low. So it'd be warranted to get some electrolytes as well. And in this case, the QTC, or ECG, we decided to get that, and it comes back at 463. Magnesium was normal. Calcium appeared low, but if we remember, their albumin was low, so their corrected calcium was actually within normal range. And I would do a repeat potassium to see if it's still low, since that could be a modifiable factor that's causing this QT prolongation. And when we did that, it comes back still at 3.2. And then if the patient showed any signs of worsening hepatic function, you could consider getting a repeat LFTs. However, the baseline that we have in this case is likely fine and unnecessary. So in summary of this case, we have a 57-year-old male with metastatic pancreatic cancer with multiple lesions to spine, status post chemotherapy and palliative radiation. He's presenting with mixed nociceptive and neuropathic pain, which is requiring frequent and high doses of oral morphine. Other first-line adjuvant agents were contraindicated or did not help. And he does present with some concerns of tolerance and hyperalgesia. So For this case specifically, methadone would be a good option for neuropathic pain, hyperalgesia, tolerance, and long-acting analgesia. And he is a patient with poor renal function. So methadone is not a concern in this scenario. However, when we looked at previous medications, when possible, you do want to try to avoid drug interactions. So he was on ciprofloxacin for a UTI, which is not necessary and generally not first-line therapies. So that would be an easy fix. Like maybe his QT was prolonged because of ciprofloxacin. You can easily switch that for an alternative standard therapy such as Keflex. The patient was also using a PPI, specifically omeprazole, which has drug interactions with CYP2C19. And if this patient was using this primarily for GERD, you can switch to an H2RA like famotidine or ranitidine to kind of avoid this drug interaction. And routine labs, which are helpful, are the electrolytes, magnesium, potassium, and calcium, LFTs, which we already had previous labs, in obtaining an ECG. And in regards to follow-up ECG, I will direct you back to earlier slides and also the white paper consensus. And then the most important thing is also providing informed consent for patients, especially if they do not have access to obtain these monitoring labs and tests. And then correcting reversible causes of QT prolongation when possible. So in this case, stopping ciprofloxacin. And when we looked at the patient's blood pressure, it was actually within a normal range. And if we're going towards more comfort-focused care, is an antihypertensive still necessary? Could we consider stopping hydrochlorothiazide, which could actually be causing that low potassium? Alternatively, if that is necessary to continue, you could consider supplementing with potassium to help reverse that. Other key things to note is you don't want to dose adjust or titrate methadone until steady state is achieved, which is at least 5 to 7 days, or 10 to 14 in hepatic dysfunction or advanced age. And then another thing that's important to note is don't forget about the bowel regimens. You want to prevent constipation, otherwise you may put patients at risk for getting an obstruction or compaction and cause a lot more complications down the line. So in this case, I would also consider starting the patient on scheduled Senna. Because it's been such a prolonged period of no bowel movement, I would consider giving them a suppository and or enema, just to make sure that we get this constipation issue acutely managed, but also needing to monitor for concerns of impaction and if they need to have digital disimpaction or manual disimpaction. And I think we're hitting right on the time. So sorry, that was a little rushed.
Okay, thank you, Theo, for that great presentation of the case. Sunil, would you want to add something to this?
No, I think if there are any questions from the participants.
And if you want to add on something.
Yeah.
And
Sir, how to take care of the acute pain, sir? Because methadone will take time for onset and peak levels. How to manage the acute pain?
Okay, so you have to use short-acting medications like morphine or fentanyl. If patient has renal failure, you can use injection fentanyl.
Financial issues are there, sir.
Yeah, so in this
Injection
case, the
fentanyl?
the patient still was responding to morphine. They were not at an ideal position, but their pain went down from 8 to 5. So initiating methadone may help with this tolerance and hyperalgesia. So it may take a little bit of time, but I don't recommend trying to react acutely with like high doses.
So shall we use the it as a continue morphine as a bridging dose till the methadone takes over?
Yep, that's what I would do.
Thank you, sir.
Yep. So, Anne, would you want to add some things here? Hello, Anne. Have we lost our connection?
If Anne is not there, Priya, I think
Oh,
you
okay.
can conclude the session.
Okay, fine. So, thank you very much, Theo and Dr. Sunil, for this wonderful session. I think the enthusiasm amongst all was really palpable, and I think we have learned that there is a possibility of something other than morphine for pain relief in India, though we have to learn and be careful about learning how to start methadone, how to use it, when to use it, and how to titrate, which I think today's session has initiated that enthusiasm for us to read till the next session. I'm sure that all of us will make an effort to go through more literature and find out really where and how we can use methadone. I think the uh, biggest indication I would see where morphine doesn't give complete pain relief, or there is a renal failure and we don't really have other alternatives to use. And I think personally I enjoyed the session. I look forward to next session as well to learn more and start using methadone. So thank you
Madam,
very much.
last
Yeah,
short
sure.
question.
Sure.
Is it safe for pediatric use?
Theo?
Yes. So in methadone has a long history of actually being used in pediatrics. In regards to dosing for pediatrics, it's going to typically be weight-based. However, I do not specialize in pediatrics, so I don't know if I can necessarily answer on that, on dosing.
Thank you,
Okay.
madam. Thank you, sir.
So we'll stop here, Sunil, and we'll meet not next
Yeah.
week. I think in